Good morning, everybody. I'm Jody Intritt. I'll be the moderator for today. I just want to give you all a 2-minute warning. I know we love talking to one another, so keep visiting for another, 120 seconds.
Good morning, and thanks to everybody for joining us for this very special event. We are here to talk about maternal fetal health in the state of Arkansas. Nationally, 24 women out of 100,000 died during or immediately after childbirth. In the state of Arkansas, that number is almost double. And the rates of maternal mortality are particularly high in disadvantaged communities across our state. Unfortunately, this is a problem that is getting worse and not better. Over 60% of hospitals in the state of Arkansas no longer provide labor and delivery services. And that means that moms, expectant moms, have to travel for prenatal care and often go without. The good news is that we are committed to making a change. And our panel today is here to help discuss ways in which we can improve maternal fetal outcomes in our state, make moms and babies healthier. I want to thank Senator John Boozman, Representative French Hill, and Governor Sarah Sanders for their commitment to this important issue and for helping us to assemble this roundtable today. We'll be joined by our moderator, Jody Ann Tritt, who's the Executive Vice President of the Arkansas Hospital Association. She will be our moderator, and our panelists include Dr. Nirvana Manning, who is the chair of the Department of Obstetrics and Gynecology here at UAMS, Dr. Lenita White, who is the CEO of the Community Health Centers of Arkansas, Dr. Sharmila Mukherjee, who's the founding dean and CEO of the Alice Walton School of Medicine, Joni Yarnell, who's a certified nurse midwife here at UAMS, and Dr. Sam Greenfield, who's the medical director of family health at the Arkansas Department of Health and professor of OB/GYN here at UAMS. Now I would like to turn the microphone over to Jody Ann.
Good morning, everybody. It's nice to see you all. I think first things first, we have some pretty important people here who have made this a very important issue. So Governor Sanders, I'd love to turn it over to you for some comments.
Sure. I'll be very brief so that we can save the bulk of our time for questions at the end. Very excited to be here and part of this discussion and event. I think that the number of people that we have engaging on this issue shows just how important it is that we address it from a comprehensive approach, and making sure that we have stakeholders from the medical community, state and federal government, I think can make a real difference in our path moving forward. I come to this from a unique perspective as the first mom to ever serve as governor of the state of Arkansas. This isn't just something that is a policy proposal, but it's very personal. I have 3 kids, and I know the importance of the care that I received, and I want every woman, every mom in the state of Arkansas to be able to have access to good care. I think one of the biggest things that we have to do is not just zero in, though, on the 9 months of a woman's pregnancy, but really focusing on the overall health of the female population here in the state of Arkansas. It's something, frankly, we've ignored for far too long. A lot of the instances where we are seeing complications from pregnancy are due to predetermined high-risk individuals and things that we could engage in and prevent by really focusing on the overall health of women across our state. We know that healthier women make healthier moms and have healthier babies. And so the more that we can focus on that, I think that we can not only improve our numbers, but improve the quality of life for people across the state of Arkansas. So thank you for letting me be here, and thank you to Senator Boozman and Congressman Hill for their leadership and partnership as we work together to make Arkansas a much, much better place to be a woman and to have babies here in the state.
I don't know how I can. Yeah. I don't know how I can top that. I agree with everything the governor just said, and we certainly appreciate her leadership in this area and so many other areas. And then also being with French and the great job that he's doing in the House, and me representing the Senate. We've got lots of problems. We could talk about Ukraine. We could talk about Israel. We could talk about the Far East with China and this and that. We could talk about our domestic problems. But today it's all about women and children. And in Arkansas, we have a problem that is very solvable. It's something that, again, coming together today, I think we can really make some real inroads. when I was in the last Congress, we were able to pass a bill, the Women's Empowerment Bill. It's really a simple thing. It just said when you're looking at foreign aid, make sure that women and children are taken care of, because all of the studies say when women do well, communities do well, countries do well. And so, as the governor just said, this is so very important, and this is a part of that. But there's so many other parts that we need to work on in the future. I want a special thanks to Secretary Mallory at the Department of Health for the great job that she does, Secretary Putman at Arkansas Department of Human Services, and members of the Arkansas Maternal Mortality Review Committee for the great work that they're doing. So thank you all for being here, and then thank you so much. I look around, this truly is the who's who of Arkansas healthcare. I know how hard you work. I visited with almost all of you at some time, and you're not a bashful bunch. That's a good thing. But I know how hard you work. I know you're under-resourced, and you just do a great job, and we want to do all that we can to make sure that we're supporting you in any way we can. So thank you.
Be with everybody this morning. I want to thank UAMS for hosting. It's always great to be back at in the Stevens building, and Dr. Patterson, thank you for your staff and leadership to bring us all together. And John Boozman, thanks for stepping up to lead on such an important issue, and Governor Sanders the same. When you think about it, this is a foundational issue. We have a lot of health concerns in the state of Arkansas, a lot of public health concerns. When you think about pre-pandemic, we were in meetings in the public health department thinking about how to tackle, with help from the federal government, HIV/AIDS in this state. We've always been concerned about obesity, opioid abuse, smoking. And yet, foundationally, our moms and their babies are at the root of all that. Because if we do an outstanding job in maternal health and in early childhood health, then a lot of these other challenges that we have are really ameliorated. So I think this is such an important issue. All I know about maternal health are the examples in my own life. Born on my mother's birthday, she was an outstanding mom. Watching Martha Hill be an outstanding mom has been an inspiration. And then in my professional life and being a dad, it's been terrific to have been a board member at Arkansas Children's Hospital for 15 years. And I know Marcy Darter is here. And the pediatric work, the care of training of our physicians, and the integration of maternal health and pediatrics is so important. So Marcy, thanks for all that ACH does. And then last but not least, I'm now an expert in this because my daughter has graduated from UAS. She's an OBGYN resident at the University of Alabama at Birmingham. So yes, I was studying for all her horrible vocabulary exams. I learned more about words I've never heard of in my life than her 4 years of outstanding education here at UAMS. So it's great to be with everybody and look forward to the discussion.
Now we'll move on to our panelists. Dr. Manning.
So sorry, guys. Oh, there it is. Well, hello there, and I reiterate the thanks. I appreciate Senator Boozman and all of you guys for coming. Obviously, this is very near and dear to my heart. Here at UAMS, I am the chairman of the Department of Obstetrics and Gynecology, and I also serve as the service line director for women's health. Both of those positions have given me an opportunity to advocate for women that I feel like I've been privileged to have. And so being asked to the table with some of these really important issues and helping to develop what that next stage of our trajectory in Arkansas will be, I greatly appreciate. So I look forward to the discussion today.
Good morning, everyone. It is nice to be back at what was my home. So I am, of course, as she said, Lanita White. I'm CEO of Community Health Centers of Arkansas. And in Arkansas, we have 12 community health center entities. We account for over 200 clinics in the state. And so it's a huge footprint. And what I found from listening to the discussions of our health centers is we had an issue in maternal health. It was not on my radar when I first came there 2 years ago, but it's very much on my radar now, as you stated very clearly. But the issue is that when we sit down and talk about it, we all lament. And so I was very excited to be invited to this panel, to be here to discuss this with like-minded people and all of the folks that are in the room that are going to also be looking at the same issue and figuring out how do we have some action behind it. So we can talk about it all day long, but we want to make sure we have some action. And so I'm very thankful for the senator inviting me to this panel. I kind of looked around and I was like, did he really mean this to come to me? And so I kind of looked around with a little bit of shock and awe, but at the same time, I'm very happy to see the engagement and the investment in time. I mean, we have our Congress people here, we have our governor here, and all of you. So it's truly an investment of time as well as energy to be here and showing that this is an important issue for us. Definitely at Community Health Centers of Arkansas, we are looking at this every day. We are facing this every day and very happy to be a part of the discussion.
That was wonderful. Good morning. My name is Sharmella Makija. I'm currently the Dean and CEO of Alice Walton School of Medicine. And again, I'd like to echo my sincere thanks to Senator Boozman, Governor Sanders, Congressman Hill for convening this important meeting to discuss this topic. In my former life, I was the chair of OBGYN and Women's Health at Montefiore Health System, Einstein College of Medicine in New York. And previous to that, I was the chair at University of Louisville. I am born and raised in Montgomery, Alabama, so I've lived all across the country and seen this is an issue that affects nationally. It's not just in Arkansas, it is nationally. But this is our home, and I consider this to be my home, and this is where we really have to focus and see how do we work together to solve this problem. And it's complicated. It's not an easy fix. And as Governor Sanders said, this is not just about that moment in time of 9 months. You know, this is how we approached it in New York. We looked at that person as a woman and what were her issues before she got pregnant. And we worked with a lot of the teams in internal medicine and other specialties to address a lot of the comorbidity or the other issues that they faced in addressing obesity and high blood pressure before it became a problem during pregnancy. So I'm really excited about this. I have lived in many states, and this is the first that I've seen this kind of convening. So it's really a privilege to be here, to work with everyone as partners, and thank you for being here to help us solve this problem.
192%, those are the key numbers. Between 2018 and 2020, we had 100 pregnancy-related deaths in our state. 92% were deemed preventable. And that preventability extends up and down the spectrum from the patient and family, from the onset of prenatal care, all the way through the providers, through the community. So it's an opportunity. So to the Senator, thank you for using your senatorial superpower to convene. That's incredible. Thank you. The state of Arkansas convened its Maternal Mortality Review Committee, and I've had the opportunity to lead that effort since 2020. So thank you to the legislators for bringing that to our state. We can't address a problem unless we know exactly what the problem is. We have a unique privilege and honor to review those lives and those families' deaths that are permanently scarred from the loss of a mother's life. And everyone in this room has a vested interest because we are products of the maternal health system. So over the whole course of this conversation, I hope that we find success. I hope that we find common ground. And I hope that we don't lose sight of the fact that in those losses of life, there's another condition to consider. And I would call that severe maternal morbidity, which is by order of magnitude where mom went home, but she didn't go home intact. So thank you for the opportunity to have this conversation, and I look forward to the outcome.
Well, I am Jody Ann Tritt. I'm the Executive Vice President of the Hospital Association. So it is the honor of my career to be able to represent almost all of the hospitals across the state. As you said earlier, we are down to 35 hospitals in Arkansas that have active labor and delivery units. And so that stresses all of us out, right? And like Governor Sanders, I'm a mom, and I want my kids to come back here and enjoy everything that Arkansas has. So I'm looking forward to moderating the panel, and I can't wait to jump right in. So I think the first question, and then you all jump in anytime you want to add extra things, questions, however you want to do it. But I think the first question, and I'm going to give it to you, Dr. Greenfield, because when we were in the green room, unfortunately, he had this great thing that he said, which is, you know, we really have to define what prenatal care is before we can talk about delivery and postpartum care. And I loved how you said that. So putting you on the spot straight away.
So when we talk about prenatal care, we know that one of the most important things that a mom can have a healthy outcome is healthy prenatal care. So what is prenatal care? Prenatal care is not just going to the doctor or going to your health care provider to listen to the heartbeat, to leave a sample, to have a blood pressure check. Prenatal care, effective prenatal care, is respectful care. It's a process of risk assessment to see where the patient falls on the spectrum in terms of what the risks are for the pregnancy. It is therapy and intervention, but not to be lost on that, it's education. It's an opportunity to educate of what to expect and what to look for and how to advocate for yourself throughout the course of it. So effective prenatal care, ideally we'd like someone to enter at about 10 weeks. Effective prenatal care would be respectful care with good quality, ideally somewhere between 10 to 12 visits, and if there are more that are needed, that's the start. And then as we have, unlike other specialties, we have the unique opportunity to have a product at the end that can actually measure our success.
I think that's right. And Dr. White, I'll put you on the spot too to talk a lot about what community health centers do in the prenatal care space.
Thank you. I love being put on the spot. That's the highlight of my day. And so, great question. So community health centers, as I shared with you all, we are across the state. And our community health centers often get people, when they walk into the community health center, we really get one chance to keep them, right? And so when they walk into the state, we're providing prenatal care, we're providing education, we're also providing wraparound services, including things like behavioral health, making sure that the mom is totally healthy before she has that delivery. The other thing that we do is once moms have delivered, we don't stop and only concentrate on baby care. Because if you think about it, in the U.S., we really do prenatal care, and then we do after delivery baby care. And one of the things that the governor mentioned is we have to make sure we continue to take care of those moms. And so we do that in community health centers with wraparound services to make sure they're getting their mental health needs met if they're their parent and there, or we found them. But then we also do other things like education, making sure they know how to take care of the baby themselves, how to identify if there's postpartum depression, how to identify if there are gaps in their health care, how to identify if there are other issues that existed before the pregnancy or issues that were caused by the pregnancy, and we continue to treat them. And so that's one of the most important things that happens in community health centers, is because we really do have a team approach. We can wrap that team around not only the mother but the baby, but most importantly, making sure we have healthy mothers that go home and keep families whole and keep families healthy.
I know we have a lot of substance abuse issues. So I'll ask you, Dr. Manning, when a mom comes to you or a pregnant lady comes to you and she's got a substance use issue, how do you address that, and how do you connect her to the right community resources if she doesn't live here in Central Arkansas? How do we work as a network?
So that's a great question and really hard to tackle. We are so fortunate here in Central Arkansas that we do have resources readily available. But it was just last Friday that I was having lunch with someone that graduated residency with me that works in rural Arkansas, and her and I were just trying to go through some of the things that she tackles every day, and substance abuse, mental health issues are a huge one for them. Now, with the aid of Representative Pilkington, we can assess postpartum depression, and we can assess it in a different way. but having the resources with which to refer them to is still a gap in our care. And so as obstetricians, I mean, we can certainly start, or as, you know, primary care, as any of these providers, we can start that care, but being able to pass that baton to a specialist that really can tackle those concerns, and especially in the long term, well after that pregnancy, well after that initial postpartum visit that they have with us, is still a huge gap in the care we have.
Dr. Makisha, I know we've talked a lot offline about workforce, and so what types of healthcare providers do we have other than OB-GYNs in our communities that can help with these wraparound services with prenatal care? How can we better build on the care that we are giving to these moms throughout our communities if OB-GYNs are not as readily available all over our state?
Right. Yes, that seems to be the theme of problems throughout healthcare, right? The workforce, access to workforce, the decline of people being actively practicing in the communities, especially in rural communities, is an issue. We see it magnified with maternal health care, especially because of malpractice rates for OBGYNs. If they're working in single practices, it's just not feasible anymore. And especially working out in a rural community where you don't have backup sometimes for some of the specialists that you need for high-risk pregnancy. So a lot of work that I think is important to do, and I will own this part as a physician. It's sometimes hard to convince physicians to not be in charge of all of the aspects of care for a mom. And, you know, even running a department in New York, I had to speak a lot to my specialists about looking at how we work at top of license. So what we're really good at, we do. And why not look at this care for a woman for the whole spectrum of her needs? And so not everybody needs a high-risk doctor to take care of her. You know, utilizing our midwives who are wonderful at doing this work for low-risk pregnancies, and we are their backups if they need. Utilizing doulas, and that has become a big topic. They don't provide medical care, but they do provide that social support and that encouragement for a patient. And the studies, the preliminary studies have shown that it does provide better care, better outcomes for women. And it's, you know, we have to work on our side of not being so defensive about utilizing all aspects of the workforce. And I think that's going to be a big plus for us to maybe lead that effort, because people are a little worried about that, physicians in particular, and just promoting that and showing how that works. I'll give you a little anecdote. When I was chair at Louisville, I saw a lot of patients go what we would say across the river to Indiana to get midwifery care. And I thought it was terrible that they had to drive so far away, and clearly there was a need. So we created a midwifery program. My residents and doctors didn't particularly like it at first. And then, you know, I ended up leaving after about a year to go to Montefiore, and then I got word that they were calling me saying, you know, they're trying to get rid of the midwives. Can you please make them stop, because we love them? And it has grown, right? So it's part of it is you don't know what you don't know, and you just always get scared of change. So I do think there are ways to really promote that, to work with our communities of midwives, doulas, and look at how do we provide better access in general for patients. And then those that need the specialty care can then come to the physicians if they need that.
Perfect. I completely agree. Goodness. Okay. And I would also add family practitioners to that list. I think in a state such as ours, where family practitioners really carry the bulk of what you know, all the healthcare in their rural communities, obstetrics is definitely part of that package. As a chairman, community hospitals come to me at the end of every year asking for residents to come into their communities. And while they certainly could use the obstetrical part of it. They can't support the other half of what an OB-GYN does, which is the gynecology, which is the surgery. They need the obstetrics, but they can't support that. And so when we think about safe obstetrics within bumpers, with areas with which they can kind of elevate that care, our certified nurse midwives and our family practitioners can serve those roles in really great ways. So I just wanted to add that.
Just talk. It's good to have help here. So I know how busy providers are. I mean, you know, we're in a situation now where, you know, you're behind, you work all day. Many of you here are providers, but a lot of you aren't. But you know how difficult it is to find a provider when you need some help. So in the course of a busy day, I guess the question to me is, how do you identify at-risk patients? You know, I was kind of looking at this and kind of coming, you know, we have a lot of teen pregnancy here. I think we're right at the top of that. But a lot of these women that are dying aren't teen pregnancy. They're in their 30s. You know, they're older. So how do we identify that? And you all have touched on it. What do we do once we find a person that is at high risk? And you've got that deep down feeling, you know, this is a person that's can, you know, potentially get themselves in trouble. What do we do with them? How do we follow up? I mean, what can be the mechanism to make sure that you know, a low income person or a high income, you know, and you're maybe in a little bit of stage of denial, you know, and things that, you know, that you shouldn't have problems. What do we do?
I think that's a great question. I think we start with the fact that 30% of all complications are unexpected. So someone that we never even expected to have one of these never events, whether that be postpartum hemorrhage or eclamptic seizure or sepsis, we do not know that with them coming into it. I think the second is using some of our technology to our benefit. There are tools, and we all have some iteration of an EMR now. At least most places do, that really do stratify risk profile. And I think creating a network within our delivering hospitals of talking with those and seeing, you know, we know that there are certain risk factors that definitely put people at higher risk than others. Chronic hypertension, diabetes, obesity, just to name a few. And so those should be placed in a different category. American College of Obstetrics and Gynecology, kind of our governing body, really delineates that pretty well and has given us some bumpers on guidelines. These patients should be seen at this frequency. These patients should get this additional kind of testing. And if anything kind of falls awry, this is what you do. The problem is making sure that all of our delivering hospitals have access to those interventions that they need, and that they can get that patient once they recognize that it's outside of the realm of that community to take care of, to be able to get them to the next best place in an efficient, effective way. I think that's another key part of this discussion.
If I could add in, I'm sorry. Go ahead. It's fine. If I can add to complement to that, Nirvana, is that, you know, during the pandemic, we saw the use of virtual care really help provide better access for our patients. We had, you know, we were in the Bronx. We had very difficult times getting patients in because it's according to our schedule, not necessarily their schedules, right? And so we were able to send out, even though insurance didn't cover it, we sent out blood pressure cuffs, and we would be on the screen with them taking their blood pressure, and we saw better access. So I do think virtual care, you know, looking at different ways of access. So in-office virtual care is going to be very important to consider. You know, I know there's always issues with reimbursements, but that's something that we should be able to address with the data we're seeing with improved access. And I think to expand a little bit more on what you said, we have standards. What surprises me is that most delivering hospitals, or I can't say most, all, are not required to document and assess and have certain rules that they have to follow if you're going to be a maternal hospital. I think they should, just as a trauma center has to be designated as a level 1, there are certain requirements. I think we should approach it that way of, we're guiding you to show you what we're using at good hospitals. Just making that a standard requirement will probably up that level of understanding of how do you assess high-risk patients. And then the third thing is, I've worked on the side of not being a level 4 regional perinatal center and then being a regional 4 perinatal center where you do receive those patients that are sicker and high risk. And, we even changed the way we did it in New York because I was accepting of anywhere a patient needed to come to us. But I worked with the other hospital systems of, you are a regional center, you need to take it, doesn't matter if it hurts your stats, you have to take them because it's better care, because the records are there with you in your own hospital system. So having bigger discussions about not being so scared about the statistics and really providing the care, and then addressing if it is poor care, then we address that as a separate category. But we have to work better at receiving complicated patients and not being worried of how it looks, because I do think that's one part of the concern.
I definitely agree with that. I think another piece of this is explaining to women when they are high risk and what that means. We don't want to scare them. We don't want to put fear in them, but they need to understand, I believe you're high risk, and this is what it means. This is where this can lead. This is why it's important for you to come to these visits. This is why it's important for you to have someone else that understands. We've talked a lot about what we can do as healthcare providers, but there is a responsibility of the patient. But their responsibility begins where we make them understand why it's important and what they need to do. And so we sometimes as healthcare providers skirt around saying patients have responsibility, but they 100% do. But we have to ensure that they understand what that responsibility is, and we help them to get there and move through that effectively.
Sorry if kind of going back to a point that Dr. Greenfield made earlier about prenatal care and being able to define that. Before you can determine that somebody's high risk, you have to see them. And one of the big problems that we have in the state of Arkansas is that we have a vast number of women who are not seeing a doctor. In fact, 1 in 35 women in the state of Arkansas are not seeing a doctor until they are actually in labor. And so they can't determine that they're high risk. They can't provide those services if they don't see them until the moment they're actually delivering their baby. So we need to do a much better job as a state, not just defining prenatal care, which is absolutely critical, but then educating moms on how important prenatal care is. That's one of the things that I think will make a big difference in the long-term outcomes and really change the trajectory of our moms delivering here in the state, is if we can get more women seeing doctors at an earlier point in their pregnancy. And to me, that startling number, it's about 1,100 women out of the 36,000 that give birth in the state of Arkansas do not see a doctor until they are actually in labor. And that's a critical piece that I think we can make a big difference on.
Thank you. That was actually right in line with what I was going to discuss. Because we can talk about what prenatal care is. Yes, that's the education piece, but there's also an education piece about access. So in 2017, I had the opportunity to go to the Department of Health, and I will lay bare my ignorance. I had practiced medicine for over a dozen years at that point in time, and I did not have a good working knowledge of what public health is and what it can do. So we have 54 maternity units, where we provide maternal care in 54 units across the state, and we are an effective gap filler. We know we have healthcare provider shortages. We don't have FPOB, we don't have midwives, and we don't have OB providers in several areas of the state. But at the Department of Health, we have an opportunity through our advanced practice nurses to initiate the prenatal care, to facilitate getting them identified with what the proper risk would be, and to refer them to the appropriate provider. UAMS has provided high-risk OB support for the health units for several years, and that's been a phenomenal boon to prenatal care within the state. But to your point, I don't know if patients really know or really take advantage of the access that may be closer than they think. So there is an opportunity for education in terms of how to use the resources that are available. So I totally agree with your point.
If I could, one of the things that our team, and a lot of them are here, I'm proud of the fact that most of the people running agencies and working on this issue in my administration are all female and moms themselves, and so very highly motivated and engaged on this topic. But one of the things that I think is missing, and to your point, people aren't aware of that access. There is no one in the state of Arkansas, if they are pregnant, that cannot receive care and cannot receive coverage for that care. And so that's one of the things that I think we can do a better job of educating people in our state and helping them to understand those 54 different community health centers that exist around the state, as well as other options that they can receive for coverage and care. And that's one of the things that we're looking at, how we do a better job of educating the female population on that specific point.
I would add, this has been such a good discussion, and when you think about running any kind of business across the state, you've got to take into account urban and rural, and we have our legislators here who struggle with this and best practices. But between the Department of Public Health operations across the state, their expertise, and 173 community health centers, and John Boozman and I have been tremendous supporters of our community health centers, particularly in a rural state like Arkansas. I agree with the governor. It seems like the gap seems to be that we're not coordinating the opportunities that we have, notwithstanding Dr. Infield's concern that 30% of complications, are not predictable. So those 1,100 women that the governor's expressed deep concern about, that they don't have even any guidance at all before they go into labor, I would ask, are they statistically a higher part of those 100 maternal deaths, for example? And then I would say, back to the Department of Health and community health centers, what can we do to close that educational gap for those moms in these counties? And then what is the specific plan we have of how UAMS, for example, provides aid to those labor and delivery hospitals? And is the midwiving a policy change the state's considering?
Well, to the question of prenatal care and outcomes, if you do not have prenatal care, your likelihood of having a poor outcome is increased. That's pretty straightforward, yes. And while we haven't released those numbers and published those numbers in terms of the number of the 100 people that we talked about that didn't have prenatal care or their numbers were low, my anticipation is, and preliminarily looking at it, is there will be some correlation there.
I think that's a loaded question, honestly. It's one of those ones I got to take that and break that down. It's a lot to process. You asked several questions, and I'm going to attempt to answer several of them. From a community health center standpoint, I think there are two issues. Number one, we are across the state. We're there, and there's no microphone. There we go. All right. So now it works. Okay. So we are across the state. I think there's some of the barriers with getting women to care early, and it goes back to what the governor was saying, that initial just overall care before you're pregnant. A lot of it, some of it is access, and access in the fact of it may be distance, it may be transportation, it may be just an awareness that you need to have primary care. So there are a lot of factors that keep women from basic care in general. Not that they don't have access to it or they can't get to it, but it's the act of getting there. It's the transportation. It's the education about it. And in some cases, particularly with young women, sometimes it's a little bit of embarrassment to go in to say, I may be having some issues I need to have looked at. The other thing is with community health centers, I'll be very transparent. We have a PR issue. Most people have no idea what a community health center is or what a community health center does. That's not just an issue in Arkansas, it's an issue nationally. We're always educating people about what community health centers are and what we provide. We see people regardless of their ability to pay, and most people don't have that understanding. So if you have women that don't have a payer for their care, no Medicaid, no private insurance, what have you, many times they believe healthcare is not in their reach. So we have to educate people that there are places you can go. The Department of Health is one of them, community health centers is another, that you can walk in and get care regardless of your ability to pay. So that is a PR issue, I think, on both sides. The other thing is, I believe, and I'm a South Louisiana girl, so I'm going to tell you what we thought about this in South Louisiana. I'm not talking about Arkansas. I'm saying in South Louisiana, this is what we thought. You go to a community health center or you go to the Department of Health, you were poor, you couldn't afford it, and it was substandard care. All three of those things are incorrect, but it's a PR issue again. So we have to explain that to women. The other thing is, the other question you asked is kind of what are we doing? How do we coordinate and use the resources? One of the things for community health centers, we see patients every day. We're seeing people when they walk in the door, we grab them and we try to endear them there, and you are our patient. But the other thing we do is partnership. And so we just received a very large grant with, actually, I think Dr. Pearl McElfish is here somewhere, but looking at how we address maternal issues in pregnancy, how we address excessive gestational weight gain to avoid some of those morbidity issues that we have after pregnancy. So we partner a lot with others, the Department of Health, with UAMS, with other hospitals. We have community health centers that are taking on the OB component of those hospitals to help them ease that burden. And so one of the things that we do a lot is partnership. I think the other issue with that, and this conversation is so important, is because we're all doing similar things, but we're not all talking about it and we're not sharing with each other. In a state that has scarce resources, we know resources are finite, and it's small and it's rural, we have to work through how we get those partnerships aligned, and we're doing a lot of the same thing and supporting each other where we're great at, right? So if an entity is great at, you know, you have a high-risk patient and you need surgery, then we can kick them to that patient. They should come back to that primary care to be seen after that. And so there's a lot of things that we're doing, but coordination is one of the issues.
Could I add something? I agree with all of that. Just to add, you know, when we look at solutions, sometimes it's helpful to look at other problems or other aspects of healthcare. And so as an oncologist, I worked at UAB, a practicing G1 oncologist. We saw a similar issue with seeing patients at a later stage of cervical cancer or breast cancer. And so we had great resources, could not get patients to understand they needed to get screening, pap smears, mammograms. So we, with our cancer center director, formulated a community health worker option. And I think that's something similar, what we're looking at even at the school and with our Whole Health Institute, is bridging the gap. I always believe you have to bridge that gap. There's a disconnect of a lack of understanding or knowledge or being scared. You know, if you go and you get a diagnosis, what do you do now? And so what we found with that model is that in their own community, there were women in the churches that would go with the patient to get their screening, and they were there when they got the results, and if it was something that they needed more work, they went with them to those visits. And we saw an uptick in adherence and coming in and getting follow-up and seeing patients at an earlier stage of cancer where we know that they're going to live longer with that. So I think there's, you know, some aspect of that modeling that I know people are working on here as well, but I think that's a very powerful way of helping bridge that gap so that they're not as worried or nervous about coming and getting something done. And what does that mean? Getting bad news. People don't want to get the bad news, but if you have somebody with you, it makes a difference.
And just to kind of add just a little bit to that, and I know it feels like we're kind of jumping around, a couple other things, and you had asked, what are we doing? At the beginning of the pandemic, we had 39 delivering hospitals. Shortly after, it came to 37, and now we're at 35. It is hard to keep these hospitals sovereign. So some of the things that we are doing is taking prenatal care into these communities with mobile units. We have a grant that we're working on right now, and how can we take healthcare where they are, kind of bridging that communication between them and such that when they do have a delivering situation, they know more easily where they need to go to. It's in the pilot stages. We'll see how that goes. I think there are good points and bad points to that. Another part of the question that you had asked was the midwives, and I hate that Joni Yarnell is not here because I think she could speak to that, but I'd be remiss to not say, we have a very robust certified nurse midwife program here. When I was in training, which I will not date myself, but many years ago, we had a program that was not as successful. It was very siloed. They worked very independent. The physicians worked independently, and there was very little communication. Years later, they came back and we work under the same umbrella. There's a lot of collaboration. There's a lot of communication with one another, and there's a level of trust. So while I think certified nurse midwives will be great for our state, I think we have to invest that time to create those collaborations and that trust.
I'll add too, Dr. White, you in particular talked about fear, right? And you have a PR problem with certain things. How can we address, let's say there is a pregnant woman who has regular medications and now they're pregnant, and what do, right? Much less a pregnant woman who maybe has a substance abuse problem and isn't talking about it. How do we address that issue across the state to sort of get rid of that fear so that new moms, especially, who do have problems, know that the healthcare providers are there to take care of them, not to turn them away or to shun them?
That's a great question, and I think if you just start. You just tanked me. You just tanked me, Nirvana. Okay, so I'm going to start with my okay. I think that's a great question, and fear and stigma exist. They just do. When it comes to things like substance abuse or even behavioral health, we have to start incorporating those conversations in regular visits. It has to be a normal part of the discussion, in addition to things like sexual health, so that we catch those issues before they happen. And so if we are having conversations with, and in this case, we're talking about women in maternal health, but in patients in general, about substance abuse, about mental health issues, about sexual health, it becomes a normal part of the conversation, just like we talk about everybody's blood pressure, right? You get on the scale, nobody says, oh, you may say, I don't want to get on the scale, but you get on it, right? It's part of the visit. We talk about your blood pressure, it's a part of the visit. And so we have to normalize those conversations to make it palatable for people to get help when they need it. The other thing is stigma is one of those things that can prevent people from walking in your door, and it can also lead to death because they don't walk in because they're ashamed. No one wants to be embarrassed. No one wants to feel ashamed. No one wants to be embarrassed, especially in front of their provider. And so for everybody that's a provider, patients being embarrassed in front of you is the worst thing ever. They don't want to be embarrassed. They don't want to look stupid. They don't want to feel stupid, which is why they don't ask us questions when they don't understand, which is why they don't say, I didn't get any of what you said, or I don't know what those words mean. They just, nod their head and say, okay, thank you, fine. And this is why you have the same conversation over and over. And so we have to start normalizing and making patients feel comfortable with talking about things that are uncomfortable. And we also have to start speaking in plain language. I'm just going to leave that on the table for you. We have to start speaking in plain language. I'll give you just a quick example, Jody Ann. My sister, she's a retired attorney. She graduated law school at the age of 22. She was the youngest person to ever graduate her law school. Brilliant woman. Every single doctor's appointment she has, my phone rings afterwards, and she says, they said this. I don't know what this means. Literally, she's brilliant. She can write a brief from the top of her head, but medical terminology, medical visits baffle her. And I say to her every time, sister, why didn't you ask them? And she says, because I'm calling you, because you'll tell me what it really means. But if she doesn't have a sister who can translate, think about all your patients that don't have that, right? And so the level of education does not always translate to our patients' understanding when we start speaking a very different language in medical terms than they're accustomed to having. The other thing is, I will say, as a healthcare provider, when I go to the doctor and I get bad news, I'm like, wait, what? I didn't hear any of that. It's lost even on me. And so we have to understand where our patients are when we see them, speak in their language, and start normalizing conversations to help them know where to go when they have serious issues.
So to the points that you're making about the visits, the sanctity of the exam room, that's a judgment-free zone. I mean, all opinions, and it's a safe space, and that should be created. To the issues of substance use in education, when our committee meets and we review the cases, we make recommendations, and the recommendations, it's interesting because I think they speak to whoever is reading them when they see what sticks with them. Our recommendations typically go patient, family, provider, facility, system, community. There's something that everyone can read in the report, and they will find something that is there. And when we make recommendations and we talk about education, the education doesn't stop with the patient and the family. The education may need to be directed to the providers. Specialized Women's Services provides substance use support in regions of the state. I would venture to say that most folks don't know how extensive it is, how to access it. And then when we talk about workforce issues, not only do we have workforce issues in the space of maternal health providers, we're going to have workforce issues, particularly in the rural portions of the state when it gets to behavioral health and substance use. So when you put on the factors of stigma, lack of information, shame, you're creating a perfect storm to, one, not access care and definitely not benefit the patients. Now, I will say, you mentioned something about apps and education and facilitating patient discovery. So within our recommendations, frequently we will say, how can you use technology? How can we use communication? And what are the resources that we can develop to actually, bridge that education gap? So I found it really interesting what you were talking about in the green room.
You want me to? Sure. Okay. I feel like we've veered off what your plans are, but but it's dynamic, right? So I mentioned that we're exploring looking at AI technology, and not so much as the how do we make things work a little faster, but my big push and our big push at the school is coming back to the basics of communication. And in our curriculum, we're really focused in infusing the arts and humanities into a standard curriculum, but really the art of communication, not of just one way of speaking, but are we really understanding if the patient understands what we're saying? And where we're using the technology is to capture the conversation. And yes, this generative ambient AI is working beautifully at creating doctor-physician notes, provider notes that lessen the burden on a day-to-day standard of how we see patients and having to spend 2 hours at night doing notes. But what I find fascinating is using this technology, and we're exploring this and we're testing it out, is the audio recordings that are captured to be able to send to patients so they can take it home and have their families listen to it, and they can listen to it over and over, not feel like having to call the doctor's office. You're not going to get the response back for days. Being able to hear it in the comfort of their home, but also for us to be able to use that for our students and faculty on coaching them on, this is how you're sounding. Have you ever heard yourself speak? Do you understand how you're coming across, the intonations? Are we understanding that they're understanding what we're saying, but providing that coaching feedback, because that is something that, I've spent a lot of time with our residents and students. How do you give them feedback? Because unless you're standing outside the door and listening to every conversation, you really can't give real-time feedback. And so we're looking at that, and it doesn't seem sexy or sophisticated, but I think it's very essential, and it's important for us to understand how to communicate better.
I will say, before we move on to delivery, because we definitely want to talk about that piece too, Dr. Greenfield, you said something earlier about prenatal care being much more than just visiting in, a doctor's office, et cetera. One of the things I know that Senator Boozman champions is nutrition, and I know that our governor has done a ton of work in this space to make sure that folks have access to food. Both of you are absolutely incredible in that space. So one of the things, and I'm definitely sensing a theme here, which is we have a bunch of resources that we haven't appropriately communicated to people to let them know that they exist. So I'm going to pass the baton to you to talk a little bit about WIC.
Sure. So WIC is a jewel that is likely underutilized across the state, probably for a number of reasons. One may be lack of knowledge. We see folks, and it's women, infants, and children. So through that first year, we should have infants enrolled. We have seen that our utilization has been below the national average. We have seen that after the child reaches a year old, they may still qualify, but they don't have continuation of enrollment. And during the pandemic, because of the need to come to the clinics to load the cars to renew the benefits, we may have seen a drop off at that point as well. But we do know that healthy nutrition, healthy weight gain, a host of these things that are important to the health of the mom and the health of the baby, because we're really talking about the mother-baby dyad. It's not just the mom, it's the mother, the baby, and the family. Those things are there, but likely underutilized. So I think that is, again, another opportunity for education and for providers to know how it works and how it can be beneficial. So, for example, if you were to take a mom who is not properly educated on WIC and the resources that are available for her for nutrition, and she delivers, let's say, an uncomplicated delivery on the 15th of February, and she goes home and she doesn't have formula, but she doesn't have an appointment until the 1st of March, what are we going to do? So we're going to say, tough it up? Nope, not a good choice. Are we going to say split your formula in half? So I think this is a question of how do we increase access and make sure that everyone has access across the state. So WIC is there, it's underutilized. There's an opportunity for education to maximize what it can do. Because we do know coming in healthy is one of the most important things to staying healthy in the future.
Yeah, this really is a really important program. We're talking about a program that helps young mothers and infants that are in poverty. They desperately need the help. I think the national average is about 55%. We're at 35%. So it's just another example of the communication. How do you make people aware? What is the drawback for people getting this benefit that really is an important benefit? Arkansas taxpayers pay their taxes. They support these programs. My attitude is we want our share plus some. So, we're leaving a lot on the table, and certainly as we talk about the problems of providing nutrition and things, this is something that we can really double down on and do a much better job.
I think that's right. And Governor Sanders, I have to give you a big shout out for all you did for the summer feeding programs and those kinds of things, and helping our kids at school who are parts of these families with mamas have access to breakfast and lunch. And I know that Secretary Oliva says a lot, hungry kids can't learn. And so a huge shout out while you're on stage, just to thank you for all of that.
Thank you. And if I could, the credit for the program's existence really goes to Senator Boozman, who helped spearhead that in Washington as the ranking member on the Agriculture Committee. A lot of people don't realize that those benefits are administered through the Department of Agriculture, and so had a tremendous amount of influence in making sure that program exists at all, and glad that Arkansas was able to participate in the program. One of the things that we learned during COVID is that our schools are very good at helping both identify and distribute meals to kids who need it. And during the school year, they're able to do that in a much easier fashion and make sure that students have breakfast and lunch. But during the summer, there's a huge gap. And right now in the state of Arkansas, about 1 in 4 kids have food insecurity. And to me, that's unacceptable when we know that we can do better. One of the things that we do really well in our #1 industry is agriculture. So with that much access in our backyard, we shouldn't have that many kids that are going hungry every day. And so anything that we can do to help chip away at that problem, we're going to lean into. I'm proud that Arkansas is able to participate in the summer version of that program so that we are helping fill that gap during those months. I'm very grateful for the leadership of Senator Boozman and all of our federal delegation for helping make that program happen and make it accessible to kids across the state of Arkansas.
All right, well, let's move on to the part that, of course, representing hospitals, I feel the most comfortable talking about, the delivery pieces of this. So, Dr. Manning, I'll start with you. I know we want to know, what are the biggest complications that occur, and then how are we working with our delivering hospitals sort of as a system to make sure that people are delivering in the right setting, and when do they know when they need to contact someone at a higher setting, right? If you haven't identified a risk on the front end and you come in, what's the process internally for how you escalate those issues?
Okay. So I think the first part of that is what was the high points, and certainly I think we've alluded to those. Healthcare issues that people come into pregnancy with that they don't get better usually during pregnancy, and those in large part are blood pressure, obesity, diabetes. Those are big three. And so as I sit on the Maternal Mortality Review Committee with Dr. Greenfield, we kind of look at each of those, and cardiovascular disease comes up time and time again. It's number one on that list. So going back to that Maternal Mortality Review Committee report, as a physician that practices obstetrics, and when I see that 92% of these deaths could have been preventable, that's a huge blow. And so I have to step back from that, and I want to kind of communicate that, because I think a lot of physicians are like, oh my gosh, like, I know we're doing better than this. And so to break that down, it's partly in the hospital, but that's just one part of it. And again, we would hope a suicide, a homicide would be preventable. We would hope that some of the educational pieces that they did not receive in the potential postpartum period could have been preventable. So I want to step back and say it is not that our physicians and our communities are doing poorly. I think some of our hospitals, and we want every single hospital in our state to remain open, do 200 to 300 deliveries a year. Those are really small numbers, and we're talking about kind of never events. So as we all work in a hospital or have touches to that, the turnover right now is tremendous. Keeping nursing staff, keeping all of the ancillary staff educated on these never events real time, such that when a patient hits the door with one of these events, we can act quickly and efficiently and be able to change the trajectory of that patient's care. So there are groups at UAMS that are going out and teaching what that looks like. So the Alliance for Innovation in Maternal Health, we joined that organization. We were 48th out of the 50 states, but we joined it about 3 years ago. And if you go, safehealthcareforeverymom.org kind of talks about that. And so these are bundles of healthcare. We're not reinventing the wheel. These have been standardized and validated. And we know that if we follow this trajectory of medicine, per se, that people have better outcomes. And it allows patients or providers and other ancillary staff not to necessarily practice off the cuff, but practice a validated system that has been proven effective. So we are going out into these communities and kind of teaching these things for a toolbox, per se. So they can open this toolbox when this patient comes in the door that they may not have necessarily seen this event before, but they know how to take care of that. I think the second piece of that is when the provider may very well know how to take care of this, but that hospital cannot take care of that patient. It's not in the hospital or in that baby's best interest to stay at that hospital. It's creating a network that they can get to the next best hospital quickly. This friend of mine that I told you I spoke with in a rural community, she had a patient at 33 weeks gestation, chronic hypertension, obesity. She knows how to do that. That's bread and butter. But that baby delivering in her institution is not going to do well. She had to call 5 different hospitals to try to get someone to be able to take her. This is in the middle of the night. This is with a full labor and delivery for her. We have got to make that process easier on our providers around the state.
Doesn't work. Oh, there it is. So you mentioned AIM and the bundles, and we now have a perinatal quality collaborative that's promoting standardized care. We've first tackled the in efforts to reduce cesarean sections. One thing you didn't mention, but I think could be added to this, is patients in distress in the middle of the night don't look to see if that hospital is the proper maternity unit. They go where they see there's a potential for help. And there's an effort ongoing right now to try, because I've received consults from, a hospital that has no OB providers, and they need help. So there's an opportunity, and there's an active effort to educate and to train those hospitals on those OB emergencies through simulation, so that when they come, they at least will be able to initiate the proper level of care. So there is an ongoing effort right there.
Dr. Greenfield, talk a little bit about the cesarean rate versus vaginal deliveries and complications and that kind of thing.
So right now, a couple of terms. We'll call it nulliparous, first pregnancy, term, singleton, vertex. That's the number. That's the term. And the idea is that if we can reduce our cesarean section rate on that NTSV, which is about, I think it's about 34%, don't quote me on that exact number, we are above the national average. If we can lower that NTSV rate, we know that we will lower the subsequent cesarean section rate. Vaginal deliveries are going to be just simply typically a better outcome associated with it. And if we have, and we've seen our cesarean section rate being high, a number of hospitals don't offer vaginal delivery after a cesarean section. So we have a gap there. And that's largely related to providers, and it may be very hospital specific. So the Perinatal Quality Collaborative, the bundle is an aim to reduce cesarean section rates by introducing standardized practices. And this is an education process from using the AIM bundles that we discussed. And it will be an adjustment in some ways, probably to hospitals and providers, because we're saying come in line with a standard practice. And if you have been practicing outside of a large group or an organization, it could be an adjustment. But this is a sort of a shift in how we think about medicine. But the evidence is clear that bundles are effective, and this is just one, and there will be more. We've done bundles in the past, but now we're looking to get more quantitative data associated with it.
I'll say I hear from my members a lot that they want to keep labor and delivery. One of the hardest things for them is being able to recruit OB-GYNs and other practitioners who can deliver, right? And one of the hardest things about that particular specialty is if you recruit only one, you burn them out completely in a community. You have to recruit groups of them. I'm seeing one of my CEOs who tells me this all the time, shaking his head in the back. But it's very important to recognize that we do need a team. We don't want to wear out our practitioners in our communities and overload them. So with that being said, Dr. Mahija, maybe we can talk a little bit about team-based care and the role of a certified nurse midwife within the hospital.
Right. Yes. Even with, and as Dr. Manning knows, even running a department where you have a captive audience, so to speak, to cover labor and delivery, it's a challenge. And there are different models that we are exploring. And, just like we have hospitalists in the hospital that now cover and round during the day, we have laborist models that we have docs that just stay on labor and delivery, because part of the challenge and burnout is that they're going back and forth from the office to labor and delivery or taking overnight call. So there are different modeling. They're good and bad with that, because there's a little disconnect with the continuity of care, because most patients would rather see their doctor that's taking care of them also be there to deliver at night. So utilizing our partners with midwives to be able to supplement and enhance the care, so that, again, triaging if they're low-risk patients, that they can take care of them on labor and delivery, and not necessarily be just the OB-GYNs. But it is still a challenge to develop that perfect modeling. And I will throw out that the the younger generation doesn't really want to take call at night. So I even faced that at Montefiore because they said, I really don't want to take call. I'm like, well, you do know you're an OB/GYN and babies have to come at any hour of the day. And so it's a real issue. So I think that having those conversations, I took that opportunity to say, well, then maybe we'll talk to our family practice partners to deliver, as well as midwives. And so it at least opened the door, and then they, there's this back and forth of, okay, well, maybe I'll take a little more call. But, it is a challenge, but I think the more we can start to show how we're working all together, then there's a less need to have 8 OB/GYNs on staff to cover the call.
I'm happy to jump in. I think one of the points too from a state perspective for us to look at, and certainly there is no silver bullet that is going to magically fix everything overnight, but one of the areas that I do think could make a difference, and one of the things that our team is in the process of reviewing, we know, to your point, that the more doctors you have delivering babies, the better off you are. Arkansas, unfortunately, has an incredibly low reimbursement rate, which sometimes makes it difficult. And so looking at, again, it's a very complicated process, but the structure of the payment and what that looks like, and if there is a better way to do that so that we have more people engaging and more people staying in some of those communities, I think could make a real difference, particularly in a state like Arkansas.
One of the areas that, because we were a hospital, we were self-insured, we were able to mitigate some of the high malpractice rates that we're seeing and have a team, risk management team. I was on that team to look at what were causing some of the big payouts. And, we had $20, $30 million payouts and a bad outcome in the Bronx. And so we were able to put in things in place in the hospital that ease the mind of our practitioners, that we're really trying to, there's not going to be a blame game. We will own it if something bad happens, but so it's malpractice, it's, reimbursement rates. I think it's all tied together. So I completely agree.
On the subject of middle of the night, high risk pregnancies in a county where there's not a labor and delivery or in transit to one nearby, does UAMS and through our trauma center and through telemedicine provide service 24 hours a day and walking a doctor through a situation like that?
We do. We have a 24-hour call center that they can get a physician on the line at any point in time. And so we have a very robust call system. We actually have a physician on call, a physician on backup call, and a certified nurse midwife every night. So we have some depth to that just due to the acuity of what we see here, but they can get a hold of us at any point in time. And if they are unable to get them to the next best place, we can at least talk them through what that stabilization looks like. But as you can imagine, they're desperate to get them out of there. And so for them, certainly they can call us and we can help, but for those transfer pieces to get to other hospitals, they end up having to call separate places.
And Governor Sanders, I sincerely appreciate you recognizing the financial impact for these things. I tell your Medicaid director a lot that most of the time she's a third of my problem, right?
She's here.
Yeah, I see her.
I'm always happy to defer to the team when it gets complicated.
Medicare's a third of my problem, Medicaid's a third of my problem, and then of course commercial payers are a third of my problem, except for when we're talking about deliveries, and I'm like, girl, you're 50%. So we're working on it. But I do appreciate very much the ability to talk back and forth with your crew and their willingness to listen to my members when they're giving them real life examples of the true problems they're having trying to make ends meet with this line of service in particular. So your staff is great, even if I pick on her every now and then.
I think they're pretty great too. So, But I do think, to your point, because we do own such a big share as a state, that's why that piece is so critical. When 50% of births are under our coverage and care, that makes a big difference. And so that's why having a review and looking at what our options are when it comes to reimbursement rates, that's not always the part that everybody wants to talk about, because it's probably one of the more complicated as well as one of the more controversial pieces of this puzzle. But I think it has to be part of the conversation, and certainly something that we're working hard to figure out the best path forward on.
Well, and we fully recognize that, which sort of leads us into, I'm being very cognizant of time, of the post-delivery piece here. Because in a lot of ways, we recognize you're working on reimbursement for prenatal care in an appropriate way. And then what wraparound services do we need to provide to women with their now growing family with postpartum care? So I'll start with you, Dr. Greenfield, mostly because you're taking notes, and just to say, hey, what kinds of wraparound services do you see working well, and what do you wish we had more of in the state?
So I'll start with the ask. More providers, particularly for people who have behavioral health issues, particularly in rural portions of the state. We do routine postpartum depression screening. We do identify it. And we do training and education when patients are discharged from the hospital. But if anybody's been a patient, you know it's a stack of papers that accompany that, and you're stressed. And so if someone is going home with one baby, or as a conversation that I had yesterday, someone who took 2 34-week babies home, they're tiny, and I know the depression is coming. I know that. And if they are going to a rural portion of the state and they're going to need mental health support, I'm already thinking about who do they have in that portion. So that's one of the things. So recognition of that. Obviously, the ongoing nutrition support is an issue that we're talking about. And then when we talk about, I'm going to bring it back to my maternal mortality perspective, we see about a third of our pregnancy-related deaths can occur in that postpartum period. We'll look at it from days 1 to 4 postpartum up until days 42, and then even out to a year. So for our pregnancy-related deaths, about 31% of those can occur well beyond what is typically the routine prenatal care visits. And so when we look at the symptoms that occur, hypertension, cardiovascular disease, shortness of breath, a host of warning signs that can occur if the patients don't know what to look for, or if the providers that they may show up seeing don't know what to look for, nor what the resources are. There's not only a lost opportunity, there's a real potential to do harm. So it's routine prenatal care, but it's a wraparound in terms of mental health support and other general health support with providers that may not typically be considered routine part of the prenatal care.
I will add to that. I like to make things simple. And so when we look at that maternal mortality review committee, and if we were to make a trajectory of the maternal deaths in the state, probably about a third of them happen right there at delivery in that hospital. The other 2/3 are all in the postpartum period. Another third is in that, discharge to 40-something days, and then the next third is in that. And those are very different ways to kind of tackle those things. And some of you may have heard of ACOG, again, our ACOG Hear Her campaign. It's the patient that presents to you with a myriad of complaints. And do you understand what she's saying? Is there a provider that can assess what she's saying? Is she able to elevate that care if she doesn't get what she needs in that community? And I think this is where our community healthcare workers could tremendously wrap around these patients and elevate that care. Healthcare is really hard to navigate. I recently had a situation with an older family member, and I know this backwards and forwards. And it was really hard to navigate. So I cannot imagine some of our patients and their health literacy and their ability to access some of these things, navigating this postpartum period on top of having a newborn child that they're taking care of. And I think Governor Sanders said it well. I mean, the mom is the unit of all of that. And when she's falling apart, everything kind of falls apart. So we really need to assess ways that we can wrap around that mom, not only in that immediate postpartum period, 60 days, but along, the long trajectory, and making sure that she is well prepared for the next pregnancy, or potentially how she can prevent that pregnancy if she so desires.
If I could jump in just to echo, I completely agree that
You're the governor, you get to jump in.
Oh, I can't. Not everybody will agree with you on that, but I'll tell them I have your permission. So, but certainly that postpartum care, and one of the things that we hear a lot about is extending postpartum coverage. But one of the big misnomers, frankly, that we have in the state is we already provide that. We just do a really terrible job of actually transitioning people after that 60-day period. And that's something that I think could make a big, big difference, that we are working hard. And I think this is where a good partnership with those of you on this side of the room can help us with, is identifying those patients, making sure they understand what options are available, and transitioning their coverage, because it already exists for women postpartum to be covered 12 months after pregnancy. We're just not moving them over to new coverage. And that's something that I think would make another thing that we can do that would have a big impact across the state, and one of the ways where our partnership could, I think, move the ball significantly.
That's a hear moment, right? Dr. Makisha, would you like to add what services do you think we need more of in the communities?
Well, first of all, thank you, Governor, because I think that is something that's not understood even nationally, and I learned that after coming here, that you have that. You actually have better coverage, more extensive than just the simple extending postpartum. It's far more comprehensive, and just, again, bridging that gap of making sure they're getting enrolled is important. I'll speak to what we call the postpartum visit. We changed the terminology to the 4th trimester visit because we wanted to emphasize to patients we're not done yet. And so during their hospital stay, we had a team that only did 4th trimester visits, and they would come into the hospital and talk to the patient and say to them, this is why we need you to show up. This is what we're going to do. You in particular have high blood pressure. We have to monitor that. We said it out loud as to why they needed to come, and they came. I think part of the problem was we weren't explaining what they need to come, because they'd come and we didn't do anything. We just did a quick check, and we didn't make it specific to them. We saw a big uptake in patients showing up for that. I think another way to also approach this is moms are always going to take care of their children. And so teaming up with the pediatrics offices to have a dual visit at the same time, because they're definitely going to show up to make sure their baby has their visit, and making sure we're doing that in tandem. We started to do that in Louisville, and I think that's a really easy way, in a way, to make sure we're coming to them, or at least team up with our pediatricians to have that dual visit. So I think those are areas where we can make sure we're capturing, as Dr. Manning said, because we are seeing the complications happen post-delivery. We always focus on delivery, but it's post-delivery where we see the complications and the morbidity and deaths happening. So that's maybe one aspect.
What did the team look like? What did that consist of? What kind of
We had, they were our OBGYNs. We did not have midwives that worked in our units, not because we didn't want them, but we just didn't have them. So we had our nurses that were in the clinics, as well as our doctors. But I certainly think midwives would be an important part of this team.
So the follow-up, so was that nurses counseling, or
we had doctors. We had the doctors. And we also, if they had a cardiac issue or heart issue, we had dual clinics with cardiology. So if it's that their primary problem was still cardiac, we sent our doctors to that cardiology clinic to see the patients there so that they weren't having to go to 2 visits, and we did dual visits at the same time.
Dr. White, I know you have some things to say about the role of community health centers in postpartum care.
I always have something to say about the role of community health centers because they are the answer to everything. No, I'm joking. I'm paid to say that. No, I'm joking. But one of the things that you talked about is having that team around a woman. And unfortunately, in a lot of our rural areas, you don't have that. You don't have the ologist, fill-in-the-blank ologist, right? And so in community health centers, we have family practice physicians, we have APRNs, we have other providers there that are wrapping those services around people. And what we want to see is that the postnatal care is the focus, because we have well baby visits, but we never talk about well mama visits, well family visits, right? And so we want to make sure that we're getting those women and capturing them back in our clinics, and we're taking care of them and preparing, I think it's what you said, preparing them for the next pregnancy or educating them on if they want to prevent the next pregnancy. But in rural areas, the issue is most of the time not having all of the specialists that you need and using the physicians and practitioners that are there fully to help take care of these women. And so that is what we have to do in community health centers, and that's what we're great at. And we do that with the resources that we have. I look at my board members, and some of them are in the audience, and watching them spread very thin resources exponentially is amazing to me. I probably need to put my personal budget in their hands and figure out how to expand what I have, because they do this every day, day in and day out, no matter what. The other thing I'll say is, when we start looking at resources, one of my board members said this and it struck me. In urban areas, you try to find resources for the patients in need, right? We have patients in need in urban areas, tons of patients, and we try to find the resources for them. In rural areas, we try to find patients, right, for the resources that we need, right? And so what happens is, in rural areas, we have all of these needs, and we don't have providers to answer those needs. And one of the questions, and I think it may have been you, Governor Sanders, that said, or it may have been Representative Hill, you have a woman in labor in fill-in-the-blank rural Arkansas. And at that moment, lots of times, if there's not a hospital near her, she knows I can get to Little Rock, or I can get to, if it's Bentonville or Springdale or what have you. And what happens is that person, her person, whether it's her husband, her significant other, mother, whoever, slams her in the car, and they're driving 110 miles an hour to get to the nearest place where I think I can take her for delivery. Lots of times they don't know to stop at the nearest ER. They don't know to stop at a place where there's a physician that can get to the 24-hour call center. And so, again, a lot of this goes back to educating women on what's your plan. If we know a woman's in a rural area and there's nowhere to deliver that baby, we need to be talking to her about, if this happens in the middle of the night, here are your steps. Here is where you go. Here's the number to call. This is what you do. Because in an emergent situation, I'm going to tell you guys, if somebody yelled fire in here right now, you'd all look like bumper cars. You wouldn't know what to do, because it's that emergent situation, and we have the adrenaline rush, and we just know I got to get somewhere quickly, right? And so we have to prepare women and give them a plan. And we don't want to talk about delivery in the middle of the night. She goes in labor in the middle of the night on a Saturday night, right? And so we don't want to talk about that, but we have to prepare people and give them the resources that they need to get to all of these things that we have in the state, so that we use it appropriately and that women are taken care of. And most importantly, women are living through the birth and then after that period of the 80 days.
Well, it's exactly 10:30, which means it's Q&A time. So don't be shy. There is a microphone over here and a microphone over there. As Senator Boozman said, you all aren't shy, so I know somebody's dying to get to the microphone.
That means the first and hardest question should go to Senator Boozman. So.
I'll ask a quick question. Thank you all so much for being here. Representative Mary Bentley, cover part of Central Arkansas. So there's one word I've been listening for this whole time, and I haven't heard it spoken one time. And I know we're doing some great things on there, so I'm going to give you guys an opportunity to share what you're doing on that, and that is breastfeeding, because breastfeeding is such low numbers here in Arkansas. We know it will improve the health of the mom and the baby drastically. So what are we doing here in this state to increase the numbers of breastfeeding? What can we do to make it better?
That's a great question. We'll start with you, Dr. Greenfield.
So that's part of WIC's mission. So when we talk about WIC and we talk about nutrition, and if we were to talk about what's the best nutrition for the newborn, it's going to be breast milk. We have a milk bank that has come online in Central Arkansas as well. So those are two very specific efforts that are ongoing. And of course, this should be part of the education that is incorporated. When we go back, I'm going to go back to the basics, to the prenatal visit. It is risk assessment. It is education, and that education can be incorporated at that point. And this is all an effort to improve those numbers. So those are two very specific efforts. Others may be able to speak to their facilities.
I think it's interesting to note, we started something called Centering in Pregnancy back in 2018. And what is that? Essentially, it's group prenatal care. It's not an additional class you take. Their prenatal care is actually with a group of very similar gestational age women. Sometimes partners come to those as well. And it's a 2-hour visit, which seems daunting because, 2 hours of your day. But if you really think about a normal medical visit, by the time you go there, you wait for a doctor, the nurse, it ends up taking about an hour and a half. This, they walk right in. It's 2 hours of education. And so over the time, we have seen some really dramatic increases with some of the things that we're talking about here. And breastfeeding, I think, is a huge one of that. And it shows that as you talk about it more, as you educate women, as you show them that it's attainable, more women choose to do that. And we know that there's lactation consultant shortages in areas of our state. We've started some grants at UAMS doing telelactation and seeing how that's going to work. But I think it's the conversation. It's continuing to have that conversation, and I think having that milk bank in our state is going to be huge.
Dr. Krause, you might want to introduce yourself also.
Good morning, Michelle Krause, longstanding UAMS faculty member and current CEO and Senior Vice Chancellor for UAMS Health. And Nirvana and I have talked about this repeatedly, but I didn't really hear you guys talk about the unique aspects of teenage pregnancy, let alone their first pregnancy, but the statistics for their second or third pregnancy during the teenage years. And so I think the group here might want to hear about that issue for Arkansans.
Sure. And I think it's important to note that nationwide teen pregnancy has really improved, which is great. We've talked about it more. We're number 2 currently as far as high teen pregnancy rates. Mississippi is the only one that's above us. And there's a myriad of ways that we can discuss this, but I think one of the most profound things that have just recently, so the statistics, we know that approximately 30 to 40% of teens will get pregnant again within 18 months. So that's sobering. And so one of the things that was passed in the last legislative session, which I'm so thankful for all of you guys, is that we now have the ability to place immediate postpartum, long-acting reversible contraception for anyone that wants it, regardless of insurance status. So to just back up, long-acting reversible contraception is exactly what it sounds like. They don't have to think about it. User error is much less. And in the immediate postpartum period, we know they're not pregnant. They're highly motivated to not be pregnant. And usually there is a form of anesthesia involved, and so it's much less painful. And so now having the ability for the woman to choose if she wants that as her primary form of contraception until she's ready to make that decision. And as we've talked about, postpartum, as much as we want to emphasize that postpartum visit, over 50% of our patients don't attend that postpartum visit. And so we lose that opportunity to talk about contraception and family planning. And so taking that to an earlier stage and talking about it in the prenatal period and being able to address that in the immediate postpartum period, I think will be huge for our state.
I'd like to make a comment about this, and I'll just say this is me speaking as a person, not on behalf of ADH or anybody, and don't worry, I'll be fine. Okay. You know, we've looked at the teen pregnancy numbers, and yes, fortunately the numbers have gone down. We still lag, and I'm competitive, and I hate losing, and I don't like to be at the bottom of any of these lists. But one thing I remember looking at a few years ago is, like, when I think about teen pregnancy, what comes to mind is the provocative teen pregnancy, 13, 14, 15. But when I look at the numbers of what the teen pregnancy actually is a lot of time, it's the 18 and 19-year-old. And so that makes me wonder, this is why I say it's me, when you finish school, if you do not have economic opportunity in your area, what is there to do? And is that a factor? And how can we impact people's futures when they finish school and go to the next phase of life? I would imagine most folks in here, when they finished high school, they knew that college was the next step. But that might not be the issue for many others. And if that is what we are seeing, I wonder if there's anything that can be done to impact their economic opportunities within our areas, so as we go forward. So I will get back on my ADH hat now.
If I could jump in a little bit, one Dr. Greenfield, I'm glad you left that answer up to the imagination and you didn't answer what can they do. But one of the things that some of you will get that later this week, but one of the things that I think is so important, and that's why it's been one of the biggest priorities that I've had since coming into office, is focusing on education and workforce development, because there are so many students that upon graduation don't have a pathway forward. And one of the big pieces of Arkansas Learns was a dual diploma. And so helping students, a lot of kids, a 4-year degree is great, but for many students in Arkansas, that is not the answer. That is not the pathway for them. And so creating a number of opportunities so that everybody has a road forward is incredibly important, and helping educate students on the variety of opportunities. For so long, we told a lie to every person, not just in Arkansas, but in the country, that if you didn't go to a 4-year college, you were somehow less than, when nothing could be further from the truth. We have to make sure that people understand that there are a vast number of career pathways that they can take, whether that is getting certification while they're in high school so that when they graduate they're going immediately into the workforce, whether that's going to a trade or vocational program upon graduation, or that's going to a 4-year college and maybe going on to get a master's or additional degrees. There is an opportunity, I think, for every student to succeed. We just need to help put those in front of them. And I think, to your point, those 18 and 19-year-olds, we have dropped the ball, and we have not done a good job of providing and explaining the number of opportunities that exist right here in their backyard. Some of them could fill a lot of the gaps that we're talking about today. Midwives, doulas, there's a huge demand for that, and it doesn't require that long-term 4-year degree commitment. So looking for those opportunities, working together, collaborating, but actually talking about it, I think is a big thing, and something we're certainly focused on in our administration.
Congressman Hill, I know you bring in 5th graders to talk about civics. We're happy for you to turn them into nurses for us. Senator Sullivan?
Yes, thank you, and I appreciate the conference. It's been great, and all the comments have been very informative. The one thing I haven't heard is any mention of fathers. We're going to wrap around mothers. We have a huge teenage pregnancy problem in our state and in the nation. We know that teen mothers are among the poorest of our nation and of our state. But I just haven't heard anyone mention the role of fathers, and I see a lot of dads in here. I don't think it was by accident that you showed up. And I think most of you were very engaged in the birth and the prenatal care. Why haven't we talked about that? And what role, if we're going to educate people, what specifically are we going to do to educate fathers in their maternal health role, or do they not have a role in maternal health? Thank you.
They most certainly have a role. And I will just speak to one specific thing that can be done. And this is actually something that can be done by everyone in here. Dr. Manning mentioned the Hear Her campaign. There are urgent maternal warning signs that a patient, a mother may experience in the postpartum period. Chest pain, shortness of breath, some of the things that you can't ignore or shouldn't be ignored. And family members, fathers particularly, can be educated on what those things are to help advocate for that mom when she is in distress. When we have reviewed cases, and we've had the privilege to review a case, nothing is more distressing than to see the polite patient turned away because she was not strongly advocated for, because she was perhaps not feeling well and she did not have an advocate. So that father being involved in those prenatal visits and being involved in that postpartum care can be very beneficial. So yes, they have an absolute role. And I would say being aware of the urgent maternal warning signs, I mean, it's literally a sheet. If you're complaining of this, be the squeaky wheel. So I would start with there, and I will leave it to others to provide more.
Is it part of postpartum? You say 50% of the people, at least in your domain, don't show up for the first postpartum visit. So how many dads are invited to that?
Yeah, I think every dad is invited, but I think in an ideal world, we catch them even before they leave the hospital. And, you know, if I think about an ideal world, it's that every woman in our state that delivers gets the same piece of information, the same communication that they get in Central Arkansas or some of our bigger hubs that they get in smaller towns. And how can we then elevate that care and make sure they have a trajectory up when they're not being listened to, or that the provider may not necessarily understand how sick that patient is in front of us.
Another question? Thank you. Thank you all for being here. I'm Shannon Jimenez. I'm the Dean at the Arkansas College of Osteopathic Medicine and a rural workforce advocate myself, even before I came here. My question is, and thank you so much for mentioning the reimbursement issue, because really that's why we're having such a hard time getting docs in rural areas. Patients in rural areas are sicker and older and poorer, so we have to work docs harder to get paid less out there. It's kind of tough to recruit that way. But my question is, as you're looking at changing the reimbursement model in whatever way that is, are you looking at a bump for those in rural areas or a bump for those who teach in rural areas? We were trying to crank out docs, but it's not easy to get them to go out there. So what kind of things are you looking at to help fix that part of the problem?
Sure. I think at this point, everything kind of needs to be part of the discussion. As I stated earlier, it's an incredibly complicated and complex payment structure. And I think we need to look at all of our options, and that's what we're working closely with our team that is sitting here. I would certainly encourage you to connect with them if you haven't, as well as everybody up here, because it can't come just from the state side. There has to be good partnership within the medical community as well. And so doing a full assessment of what that structure looks like and what options are available, that's kind of the phase we're in right now, so I don't want to be overly prescriptive, but I think everything has to be on the table in the discussion.
Yeah, it's really difficult. You know, right now we're looking at a 3% Medicare cut, and I don't care what business that you're in, if you're not receiving an increase, then you're going the other way. So you're not only getting a cut, but your expenses have gone up. And I would argue that probably in the medical field, expenses have gone up as much as any place, if not more. So every year we're fighting that. We need to redo the model. We redid it several years ago, and it just hadn't worked. It did for a while. But now we're back to every year, and I understand this. I'm an optometrist. My brother was an ophthalmologist. I understand how difficult it is. But we're getting to ourselves in a situation now. You have the great insurance, you can have Medicare, but if you can't find a Medicare doctor that will accept new patients, or our doctors are starting to only see so many Medicare patients during the day, rationing in that way, we got a big problem, and that's where we're at, along with Medicaid. So these are problems that it's really going to take It's going to take the states, it's going to take Congress, it's going to take people like you, our providers, working through it and coming up with a model. Right now, as far as reimbursement, sadly, Arkansas, and there's several other states in this boat, but I think Arkansas is next to Puerto Rico as far as reimbursement for Medicare. So it's a huge problem. It's something that we've got to work on and form. We actually were able to be a little bit helpful not too long ago, but we've got to form the coalitions, both in the House and the Senate, with our other states that are in the same position to bring it up.
Thank you all. Another quick question. We keep hearing the word midwife over and over and says some of our workforce issues, but in Arkansas we had the least number of certified midwives in the nation, the least number of deliveries assisted by a certified nurse midwife. So we know that in other states that have great maternal health, they have a lot more nurse midwives. So what are we going to do to increase the number here in the state?
In terms of the workforce issue, I think I'll let Dr. Manning discuss what we have done in the state, but I will, just as a point of education, make some clarification in terms of what a midwife actually is and the types of midwives. Within the state, we have certified midwives, which are a licensed lay midwife program, which attend, I think we have around 30 within the state. They do about 300 deliveries statewide. We have certified nurse midwives, which are advanced practice RNs who practice midwifery. We have a large contingent here in the central part of the state, but we don't have many in the rural parts of the state. So that is definitely an opportunity. So I just wanted to just sort of lay that out there in terms of having the conversation about midwifery and the midwives that we have in the state. So there's definitely an opportunity to bring them in, and I think collaborations with hospitals, and that is a great opportunity to assist and provide care for the low-risk, appropriately leveled patient.
Yeah. I completely agree with that, and I would say that the closest school of midwifery right now is Memphis, and they are fairly new in that trajectory. We do not have one here, and quite often they go much farther than Memphis for that schooling. So there certainly has been discussions on what it would look like to create that school here, and I know I've met with the College of Nursing, and I think there will be some work as far as creating a pilot program or what it would take to create that workforce, and I think then comes the even bigger step of creating those collaborations within the hospitals.
Hi, I'm Anna Strong. I'm with the Arkansas chapter of the American Academy of Pediatrics. I was so excited to hear some shout outs for the pediatric world today because, as y'all mentioned, sometimes our pediatricians see moms 3-4 times before they ever come back, if they do come back for a follow-up visit. So very excited about that. And also just want to give the governor and her team and DHS a shout out for covering services like screening for postpartum depression in the pediatric setting, billed to a child's Medicaid. Really recognizing that tie of mom's health and baby's health. I think that's so important. And also for covering the services provided by Healthy Steps in Arkansas. And this is something new in our state where we embed an extra person in pediatric settings. It doesn't have to be a pediatric practice, but a primary care setting to help really wrap those supports and services around families with infants and toddlers. We're so excited about that. One of the things that we are hearing out of the practices that are doing this is that maternal health, food insecurity, those are some of the top needs that those Healthy Steps specialists are dealing with families. And I'm so excited we talked about that today, but wonder if there are opportunities to more formally coordinate care between maternal health and the pediatric or family physician world. A lot of the times we'll refer that mom or the family back to a provider, but that may not actually happen. So what are the ways we can help avoid this breakdown and kind of the separation of the infant and mom worlds and help bring us together as a whole team? I see Representative Hill clapping.
I can just speak to, I guess, a small part of it, and I think this is something our rural communities do actually better than some of the more urban places. There are so many subspecialists in the more urban places, whereas in the rural communities, your family practitioner really takes care of that whole family. I know I have two faculty that are at Arkansas Children's Hospital that are pediatric gynecologists, and I know there's a pilot that they're starting, if not already started, kind of taking care of that mom and their newborn at the same time, if possible. And I think creating more of those opportunities, it's definitely a harder hill to climb in some of the urban places because, say in my clinic, we're not necessarily equipped to take care of pediatrics. So we would really need to think outside of the box on how that would look. But I think it's certainly, you know, something we should discuss, and I agree, taking care of that whole family for the sheer convenience of it would really push the needle on a lot of things.
Hi, thank you all. I am Sherry Turner. I'm the Associate Dean at Arkansas College of Osteopathic Medicine, but I'm speaking because I'm an ER physician. I'm the one out there in that little hospital, unprepared, delivering those babies. Have you all considered, just out of the box, we built a trauma system in the state that has transport, has designations, and has definitive care for patients. Can we not establish that for maternal fetal health? I mean, that is an infrastructure. When they come to me in that small ER, I deliver them. It may take me hours to get an ambulance because we may only have one in the county, and they can't leave to transport them. So there's a lot of work outside of this structure that needs to be done. That's all. Sorry.
I will just speak to that very briefly because those exact things are what we're discussing. And so I think I appreciate you bringing up that point, and I think it's everyone in this room. That's the discussion with regards to that. We've created the bones of that. We have a trauma system that really coordinates that care, and that's a much larger. I mean, I think there's 100 and. I'd be lying, but over 100 ERs in that system. 35 delivering hospitals and hopefully bumping it could be a very doable thing. Creating those perinatal regionalizations where we are then able to monetarily as well as resource-wise compensate those hospitals to provide that care, creating a network where a provider can call one place and they create what disposition that patient goes to. They go to the next best place. Not everyone needs to come to a tertiary care hospital. There are lots of hospitals that can take care of, a 36-week, a 34-week gestational age really well and help support those hospitals. And then creating this network of education and support with the AIM bundles. So I think those conversations are being had currently.
We've had designations of levels of care perinatally for a while, but this has been an ongoing discussion, and it's great to hear that that opportunity is there. And I think we recognize that there's an opportunity there. But this conversation has been going on, and I think that's really encouraging to hear what you're saying, Dr. Manning.
Good morning. My name is Keisa Smith. I'm the Executive Director for Arkansas Advocates for Children and Families. I want to echo all of the thanks to Governor Sanders, Senator Boozman, Representative Hill, and our amazing panelists for this event. I would be remiss if I did not ask, now that we're starting to talk about solutions, what are the next steps, especially leading up to the 2025 session? Because here recently, there has been an increasingly large amount of conversation about maternal health in Arkansas. And in this room, I can probably see about 2 or 3 different convening groups that have all gotten together and talked about what we can do, how we can do it. I just said this to my friends at DHS. There's a lot of us talking about this. And so I would like to ask, what are the next steps and how can we all of the great minds in this room participate in the conversation around solutions?
I'm happy to go first and then let you guys jump in. One of the things that we've been working on, I think one of the best parts of what you just said is that a lot of people are talking about it, which has not been the case in the past, is now we have not only awareness of, frankly, all the things that need to happen, but we also have high levels of engagement from all of the various stakeholders. One of the things that we've been working on is a comprehensive statewide plan to specifically address maternal health here in Arkansas, and working with our team, most of whom are here, and also in conjunction with a lot of the groups that you're talking about. Bringing all of those people together, I think, is how we get there. And this is a big first step. But one of the most important things is people are actually paying attention to it now, and they're going to demand that we do something. And so sitting back and doing nothing is simply not an option. I think it's why it's so important that we have a good partnership, but also that there is open line of communication between, again, the healthcare and medical community, as well as the government side and all of our agencies working together to address the problem. Sitting here, I think, is a great testament to how far we've come. A couple years ago, you would not have seen this group of people having this conversation, and certainly not in such an open and transparent way. So we're making progress, but to your point, we have a long way to go, but I think this is a very good first step, and we're hoping to announce some of the specific recommendations that we have of our plan from the state perspective in the next few months.
We've got time for one more question.
Hi, I'm Alan Nichols. I'm with Mainline Health Systems. We're an FQHC in Southeast Arkansas. We recently, a year and a half, took over the OB program at Monticello, now Baptist Health Drew County. And one of the core issue in the rural area is I think every hospital would love to keep their OB. I know it's tragic when they lose it. And you want to keep that care as close to the patient as you possibly can, but it's about critical mass. And so you need at least 4 delivering physicians on rotation to keep a program. Otherwise, it's under constant pressure to be closed because they just don't want to work in that environment. You can't recruit them to that environment, new ones. So you need at least 4. You need 200 deliveries per OBGYN per year to pay for them. So now you need 800 deliveries to cash flow this program. So that can't happen everywhere. So we really do need, when you say the trauma system, we need exactly that. We need this hub and spoke program that has delivery areas out in the state that feed up to higher level care, that's all coordinated and everybody works together. I know that I don't know how many phone calls or videos or whatever I've been in the last year and a half, and everybody has a great plan and none of it is coordinated. They're duplicating activities all over the place and they say, wow, I had no idea you did that. Well, we really need a coordinated plan. It's critical, or we're in a state with very little resources are going to waste a lot of them.
That's a good hear also. Do you have any last comments, Senator Boozman?
Well, the only thing I would say, thank you for being here, and this has really been a great discussion. I've had the opportunity, like I say, to visit with most of you throughout the last several years about many issues regarding health care, but this has been really helpful to me, talking about the different aspects of this, and really very encouraging. As was said, we've got a lot of want to. We've got to harness that, and my hope and prayer and crossing my fingers and toes is that we can get together in the not too distant future. The good thing is we know we've got good statistics now. We know where things are occurring, how we can help, that we can get together again and then celebrate the fact that we've saved a bunch of lives. That's really what it boils down to. So thank you all for being here. Thank you all so much for our panel, making time. Everybody's so busy, and especially the governor being here and lending her leadership and want to get these things done. And then again, I see a bunch of our legislators here. Thank you all so much. The nice thing is you hear about, do what?
We should get them to all stand up.
Yeah, stand up. So thank you all so much. you hear about all the rancor, at every level of government, Democrats, Republicans. What I love about these things, this brings a lot of strange bedfellows together. And those are good things. This is not a Democrat or Republican or independent thing. This is just trying to figure out solutions so that we can help people. And doing that in good faith. And because of that, I think we've got an excellent opportunity to really move the needle in this, and then, work on other things as we go forward.
I just would thank Senator Boozman for bringing us together on such an important priority for the state, and having Governor Sanders here to demonstrate this is a key component of what she has in her leadership of the state. This is a problem we can solve. This is a problem we can drive the number down. You've got remarkable talent here, but I couldn't agree more with my friend from Lower Arkansas on coordinating and making effective all the resources we have, because so much of government policy, whether it's state or federal, ends up being siloed with tremendous duplicative administrative costs and people who measure what's being measured. And so it's so important to hear this kind of integrated talk today under the governor's leadership about how to streamline that and deliver outcomes for our babies, for our moms, for our families. So I was really inspired by this and hope that great will come from it. And John Boozman and I want to be, and our whole delegation, want to be firm federal partners in helping deliver the resources in the right way to help get this done. Nothing would be better than to right the wrongs of the failures of our predecessors decades ago that did not get Arkansas the right reimbursement rate. I mean, let's just rip the Band-Aid off. That's the issue. And we are hurt in this state. We face national healthcare inflation, national healthcare wage rates, national supplies pricing. There's no differential because we're down here in Arkansas. And so that's why John and our whole delegation, we fight every chance we get to leverage the ability to get a better reimbursement rate, whether it's for CAID or CARE, we're going to do it. We're going to take that effort because we know how it rations the care to the neediest people in our state. So thank you. And Governor, I want to yield to you, please.
Sure. I just want to say thank you for letting us be part of the event, and Senator Boozman for convening this group. To your point, we have incredible talent, some of the smartest, most capable people that we could have in the country, leading both from a provider and healthcare standpoint, as well as our team in the administration. And I think collectively, Congressman Hill, to your point, this is something that we can solve. We can do better than we are, and frankly, we have to. The people of our state deserve better than what we're giving them, and if we work together, we stop siloing off, and we really have a coordinated and collaborative effort, we can make a big difference. And at the end of the day, there's a lot of things talked about the economics of it and quality of life, but ultimately we're talking about people's lives. And that is, there's no price we can put on that, and we have to be willing to lean in and make sure that we're doing everything that we can to protect the people of this state. And I'm confident that with the brain power we have over here and the desire that you have over here, no offense to my friends on the right here, but I'm going to give them the brain power side. But collectively, along with our partners in the legislature, we can do great things for our state, and I know that we will. So thank you for letting us be here today, for the work that you're doing in this effort, and we promise that we will do our part in helping address this problem for the state of Arkansas.
Well, I had one job, which was to get them out on time, and I have failed. But please do keep your seats. I think the three of you have to go to the press room next door.
We'd rather stay here.
And give them a round of applause. Thank you, everybody, for coming. It's been a great event.